Last question, Dr. Botniger. So often you hear folks have to leave the country to get leading edge treatment. That's a shame. We should be that leading edge, and we should have a system that accommodates it. Could you talk about the difference between our system and one that seems to be working better, which would be in Europe, in terms of how they've done provisional approval? And please comment on that, because if that's better, we should at least be emulating that.
Thank you, Senator. It's a good question, and I think it's debatable which one is better. I think it is true that there are certain therapies where access is more elsewhere. I think our regulators are clearly top-notch. The world looks up to the FDA for what they're going to do. But I think there are times when there are delays which are unnecessary. There are situations such as approving drugs early in the process where we don't have the same considerations. So just very quickly, because I know we're almost out of time, the accelerated approval pathway as it exists in the US really is focused on two constructs. One is you have a known biomarker or a surrogate that predicts benefit. And the second is an intermediate clinical benefit that predicts ultimate use. The challenge with both of these is that neither of them is really present in most rare disease situations. Last year, CDER approved 37 drugs. 6 were accelerated. 5 of them were oncology drugs. 1 was a non-malignant hematology drug. The point is that oncology is an area where these diseases are really well understood. Other rare diseases, we cannot use the pathways. Europe has prospectively defined certain things that they can do on a regulatory side. You can negotiate a study design with the regulators prior to approval and get an approval in that manner. We don't have the same provisions.
Thank you.